Hey guys, this is CT4071 for our positioning class. We are still under lesson 1 for the brain, the CT brain anatomy and procedures that we'll be doing. We're talking about, we're going to do 3 separate exam body parts today: temporal bones, orbits, and facial bones, sinuses. We're going to start with the temporal bones. The organs of hearing and balance are located in petrous ridges of the temporal bone, and because these organs are tiny, thin slices have to be used. Once the scan data is acquired, the 2 petrosal bones are reconstructed separately so that the display field of view can be reduced to ensure optimal resolution. Most protocols include scans in both the coronal and axial planes, and the use of IV contrast varies according to the clinical indication. But basically, scanning these tiny bones requires, number 1, thin slices, number 2, small targeted displayed field of views, and number 3, high resolution reconstruction algorithms. So after the AP and lateral scouts are obtained, 1 to 2 millimeter images are acquired in the axial plane. Multi-slice scanners have eliminated the need to acquire images in the coronal plane prospectively or at the time of scanning, which reduces the radiation dose to the patient. The start location of the scan lines is just below the mastoid process, and they end at just above the petrous ridges. The scan lines should be open laterally to include the EAM and part of the auricle. The left and the right internal ear complexes are magnified and submitted separately in a bone algorithm with a wide window and level of 4,000 window width and a 400 window level. Indications for CT temporal bones without IV contrast include trauma to the skull and petrous regions, and reoccurring infections when conventional treatments fail, congenital external canal malformations, and cholesteatomas, which are squamous epithelium that's trapped within the middle ear and the mastoid. IV contrast indications are vascular abnormalities, inflammation, and suspected neoplasm. As I said, the temporal bones are submitted in a very wide window level setting with a 4,000 window width and a 400 window level. You'll see the images they're almost grayed out, but it shows those tiny bones really well in that window level. Slides 32 and 33 demonstrate the main anatomy in the axial plane. As you can see, right and left are magnified and submitted separately. On the left, the incus and the malleus are demonstrated. On the right, the mastoid air cell complex and the occipital bone are shown. And when we get to the images that are in Romans, there's a nice drawing beside. She has drawings beside the images, if you notice. But the drawing shows the malleus really well. She's got a nice image of that malleus too. This slide shows in detail the various foramens throughout the petrous ridges where the vessels and the nerves pass through in the axial plane. A lot of these foramen are important for the CT registry. I've heard that they ask about these foramen, so it would do you good to kind of know these: the foramen spinosum, the foramen ovale, the Vidian canal, the main ones there, and the jugular foramen as well. Slides 34, this is the one I was telling you about that's got the nice image of the malleus. It's number 2 on the image there. The slides 34 and 35 represent the most important anatomy in the coronal plane. You're going to need to be able to distinguish between axial and coronal temporal bone images, so familiarize yourself with those. So instead of going over the imaging protocols for each one of these positioning or each one of this anatomy, I'm just going to leave it to you to look in the back of the book at the protocols and just refresh your or review them and look at the thickness of the slices and where the scans begin and end. So 34, slide 34 here and 35 are from your book. And Romans, you need to know this anatomy. They're both in the coronal plane. Okay, next we're going to look at imaging of the orbits. CT of the orbits is most often performed for trauma. The patient is supine on the CT table and an AP and or lateral scalp is obtained. 1 to 3 millimeter slices are acquired parallel to the IOML. Coronal images may be acquired but are usually reconstructed from the axial prospective images. The start location for the orbits is just below the orbital floor and the end location is just above the orbital roof. Images with soft tissue and bone algorithms are submitted for viewing and a small display field of view is utilized. Indications for orbits without contrast or trauma and foreign body. Indications for orbits with IV contrast are vascular abnormalities, inflammation, infection, suspected neoplasm, and thyroid ophthalmopathy. It's a hard word to say. Okay, if you're through laughing at me, ophthalmopathy is the correct pronunciation of the word. I knew that, but anyway, let's move on. Sorry about that. It causes proptosis, which are bulging eyes, and it's associated with Graves' disease. On CT, the extraocular muscle bellies enlarge, and they cause the eyes to bulge out. So what we're looking at on here is a bulging belly of these extraocular muscles that are pushing the eyes forward. So you can see that here and here. All right, the window level and the window width for CT orbits for the soft tissue algorithm is a 40 window level at about a 400 window width. But most often for trauma, only the bone windows are submitted, and they are at a window level of 400 and a window width of about 3,000 or so. Slide 39 begins anatomy of the orbits, and as you look at this axial slice, you see how far back the scan is extended. It's only slightly posterior to the sphenoid sinus, which is all that's necessary for orbits. This is why a lateral scalp is necessary. An AP scalp allows you to adjust the scan lines in the inferior and posterior locations, but a lateral scalp allows you to adjust them from anterior to posterior. So you can adjust up and only include the orbits in your scan. The anatomy on the slide includes the sphenoid bone, the ethmoid sinuses, lateral and medial rectus muscles, and the optic nerve. Slide 40, it's a detailed image of the extraocular muscles and how and where they attach to the eye. We also see different parts of the eye, the lens, anterior and posterior chambers, and globes of the eyes. The ethmoid sinuses, optic canal, and the sphenoid sinuses are also pointed out in this image. In the coronal plane, on this slide we see cross sections of the extraocular muscles and the optic nerve, how they all are related to each other and coming up, attaching to the eye. This is a sagittal NPR, very useful in showing the globe of the eye in profile, as well as the extraocular muscles around it. The orbit anatomy is spread out among the brain and the sinus or facial anatomy in Romans, but in DeMaio there are some images specific to the orbits that you want to look at. All right, so let's start with the sinus and facial bones. CT sinus screening is intended as an inexpensive, accurate, and low radiation dose method for confirming the presence of inflammatory sinonasal disease. If confirmed in the patient, then they'll have an endoscopic sinus surgery, and the coronal images can sometimes provide a roadmap for the surgeon. When the clinical indication is recurrent or chronic sinusitis, the study is done without IV contrast. There's differing opinions in the textbooks that we have. DeMaio advocates that the sinuses should be scanned in the axial plane parallel to the hard palate. Roman advocates that they should be scanned in the coronal plane. So with the new multi-slice scanners, either method is acceptable because the technologist can reconstruct either axial or coronal images from the perspective images that are obtained in whichever plane they were obtained in. So this brings up another topic in that it used to be common practice to scan the patient in axial and in coronal planes, but that's no longer the case in most facilities with the multi-slice scanners. The advantage of scanning in both planes is that the technologist is able to demonstrate changing air fluid levels and other sinus-related diseases because the patient actually changes planes. And so as the patient actually changes planes, so does the fluid level. Could be obscuring some other disease on the floor of the floor of the antrum of the maxillary sinuses in the axial position. The advantage of scanning in one plane and reconstructing the other is that of a lower radiation dose and a faster scan. Acquisition should extend inferiorly and anteriorly to include the maxillary and ethmoid sinuses, superiorly to include the frontal sinuses, and posteriorly to include the sphenoid sinus. If the facility you're at only requires an AP scout, then your centering at the gantry has to be precise to ensure that there's enough coverage below the sphenoid sinus when scanning in the axial plane. When scanning in the axial plane, the patient is supine. When scanning in the coronal plane, ideally the patient's prone with the chin extended in the head holder. An alternative for scanning coronal is to position the patient supine with the head hanging off of the end of the table. And there are head holders for that. This is beneficial for obese patients or patients with large breasts, or patients who are unable to tolerate that hyperextension of the neck and the pressure that it puts on the neck when they're laying prone on the CT table. Examination of the facial bones should also include axial and coronal images. Scan coverage should be adjusted to the area of interest. It's common in some facilities to not include the mandible when planning the scan if it's not an area of interest, but most facilities, the ones I know of, do include the mandible. Both standard algorithm and bone algorithm reconstructions are necessary to optimally display soft tissue bony structures and bony structures. Requesting physicians may order a TMJ CT. These would fall under the facial bone category and be limited to the area of interest, which of course would be the TMJs. On those, you're going to do axial and coronal thin sections of 1 to 3 millimeters. And it's recommended that they're performed in the open and closed mouth positions. So indications for CT sinus and facial bones without IV contrast, which is routine, include trauma and sinus disease. Indications with IV contrast include suspected neoplasms, which require a scan delay of 3 to 5 minutes after the start of injection, inflammation, and vascular abnormalities. The recommended amounts of injection rates of IV contrast are also noted on this table as well. The CT sinus and facial bones are usually submitted with both soft tissue window levels of 40 and a window width of 400. And then the bone windows are going to be a window level of 400 and a window width of about 3,000. Okay, let's look at the CT sinus anatomy. This is an axial image. Starting at the anterior portion of the image, we see the nasal bone, or actually the inferior nasal cartilage. The nasal septum is viewed and slightly deviated as it courses down posteriorly. And this could be because of the nasal concave beside the nasal septum on the left side that are inflamed. Now they're inflamed because of the completely opacified right maxillary sinus. You'll notice that the left maxillary sinus is black and the right maxillary sinus is gray. Remember that on CT, images that are black always represent air, and then the thick mucus that's opacifying the right maxillary sinus is gray because it has similar density to the soft tissue surrounding it. On the right maxillary sinus, the zygomatic arch is taking off, and we also see the mandibular condyles coming in. Medial to the mandibular condyle is the pterygoid plate, which is posterior to the maxillary sinuses. The red numbers in these images, in this image, were already there. They have no significance other than marking what we're talking about. It's another axial image. Slide 40 is specifically for facial bones. Starting in the anterior portion of the image on the left globe of the eye, there's a glaucoma drainage device. Immediately below that is the zygoma. Moving to the middle of the image, you can see the ethmoid sinus complex. To get a perspective on the location of this anatomy, if we were looking at the previous slide, I'll just go back to show you what that looked like. If we're looking at this slide, in order, we would see that this slide is actually superior to that previous slice. So the ethmoid sinus appears superior to the maxillary sinus. There are three portions of the ethmoid complex. There's an anterior, a middle, and a posterior. Just posterior to the ethmoid sinus complex is the sphenoid sinus. This coronal view on the left includes the ethmoid sinuses superiorly, the maxillary sinuses, and the nasal cavity. To the right of the image is a drawing that represents the osteomeatal complex. This drawing will just help you understand how intricate the design of the nasal passage really is. You don't necessarily have to memorize it, but it will it'll help you. The next two slides are examples of sinus disease. I threw them in to show you just how opacified the sinuses can become. We'll cover more of that in pathology. But you can see this left sinus is completely opacified along with the osteomeatal complex up here. Here it is again. This is the left side, osteomeatal, called on our multiplanar reformats of these, axial, coronal, and then here's a kind of a mip view and a sagittal image. On this axial view, you can see what's called mucosal thickening, which is the mucosal lining of the maxillary sinus that's inflamed. Sometimes a fluid level will form. This could be a combination of both inflammation and fluid level, but it looks more like inflammation. The white arrows here, the lining is inflamed, and this could be a fluid level, but it really looks like this whole lining is inflamed. This is a coronal view of the sinuses starting just posterior to the maxillary sinus and is in fact cutting into the posterior wall of the maxillary sinus. Below the sphenoid sinus is the nasopharynx area and the lateral and middle pterygoid plates, which make up the posterior wall of the maxillary sinus. We also see the mandibular rami coming into view, and there's a tooth in each one in this slice, here and here. The following 3 slides are from your text. They're coronal views, and there's one that I didn't post on the presentation, but it's included in your text, and I would encourage you to learn this anatomy. It covers the orbits, facial bones, and ocular muscles, the nasopharynx region, and the muscles of the face. Protocol for sinuses and facial bones is at the end of the chapter. Are very similar, but there are subtle differences. So when you look at those protocols, just kind of keep that in mind. Also, there's a lot of intricate anatomy, especially in the optic and the ethmoid sphenoid area. That would be to your advantage to memorize. You'll see that again, I'm sure. And as I said, most facilities with 16 slice or greater scanners will reconstruct either axial or coronal slices to limit radiation dose, and this is now common practice, but I assume that on the board exam we'll still have questions regarding scanning in both planes to acquire images, because it's sometimes necessary to obtain a true fluid level in maxillary sinuses of the patients, and those requests are usually going to come from a ear, nose, and throat physician. All right, so this concludes our lecture, Sinuses and Facial Bones. We'll pick up next time with the larynx, I believe.